Janet's been in private practice as a nutritionist for over 16 years and has just completed her doctorate at the School of Medicine in the University of Queensland through the Princess Alexandra Hospital. Janet has also lectured at Endeavour for over 11 years and is currently a Senior Research Officer with the Office of Research here at Endeavour. So obviously been entrenched in the natural health industry for such a long time, and yeah, I'm really looking forward to tonight's session.
Thank you very much, guys. I would like to welcome you all tonight, and thank you so much for taking out your time just before Easter. And I realise that all of you guys are nearly ready to go on a holiday, and I can so see why. But tonight I'd like to talk to you about using patient-reported outcome measures. Now, I don't know how many of you have actually used them in your practice before, but what we're wanting to do is actually encourage people to start looking at patient-reported outcome tools as a quantitative measure for outcomes in your clinic. And at the moment, what we've actually found in a naturopathic but also complementary medicine area is that a lot of people use subjective measures, which means that we look at how people are doing by the questions that we actually ask. What we have available now is these patient-reported outcome tools, whereby we can actually use these tools to actually measure and quantitatively measure exactly how our treatment protocols are going and if they're actually working or not, which will actually encourage us to have a better protocols, but our own protocols, to know what will work and what actually doesn't. And obviously, because we work as an individuals, we look at the patient as an individual, we want to know what is actually working for that person, and then we can actually change things according to these. So if you haven't come across these before, this is going to be some really good information on tools that you can actually use in your normal clinics and practices on a daily basis. So just to introduce you to, oh my goodness, why is this, I'm really sorry, but it's not going to my next slide, and I'm not sure why. Oh, here we go.
Okay.
No, we're good. Okay, just to explain what patient-reported outcome measures are, we call them PROMs. So you're going to hear me call them PROMs throughout because it's much easier than saying the whole things. What they are is questionnaires that cover issues of a specific concern for those particular patients. And the patients provide information by completing these self-administered questionnaires themselves or via an interview. Most of the time the patients actually fill out the questionnaire themselves, so we're getting direct patient-centered information rather than any judgment or professional assessment by practitioners themselves. So they're usually used to assess an outcome of an administered intervention. Therefore, we can actually use these both in a clinical setting, say in a clinical trial, or we can actually use them in our own clinics to assess what we're actually doing. We can then actually collate these and be able to do that into a case study if we want to be able to present that, or we can actually use it in our own clinics to actually know what is actually working best. So why do we actually do this? Like I said before, it allows a quantitative measure of their treatment protocols or our treatment protocols rather than a subjective measure or our own judgment or perception.
Excuse me, Janet. I just want to come in here at the moment. Are you moving? Have you moved off your main slide at the moment? Or you're?
Yes, I have.
Yeah. So,
are you not seeing that?
No, I'm not. I just want to ask anybody can. Yes, now I can. So.
Now you can?
I've got the overview for Endeavour coming up now, so...
Perfect, okay. Has everybody else seen the same thing, or is that...
Yeah, we're just getting some messages through now that they can see it now as well, so...
okay.
Yep.
I'm not really sure why.
Okay,
but
we've got it now. I've already got a question. You'll be able to... You will be sent the slides at the end of this as well, so, but yeah. Please, if there are any issues that you've received during the session, just let me know. But yeah, okay, over to you. I can see it now, Jen.
Yeah, excellent. Yeah, you are more than welcome to have all the slides from tonight so you actually go through, because we will be going through a lot of the PROMs, and we'll be able to send you the links for them so you can actually use them in clinic as well. So what we're doing currently, and I've actually been in charge of, is we're going to implement a lot of these PROMs into the Endeavour clinic settings, and we're doing that universally across Australia to all the actual clinics, so we actually have consistency. What we're encouraging is a lot of the students who are now coming out to be able to use these to quantify their practices. So what we're also wanting to do is actually educate a lot of the alumni or people who have actually already obviously qualified and are out in practice to start using these as well, which is why we're actually doing this seminar. So it's not just for naturopaths, nutritionists and homeopaths. What they actually have quite a few specific ones also for acupuncture and musculoskeletal. So the way we're going to do it at Endeavour for the clinics at the moment is that we have 6 that will be used universally across all modalities. And then we have some specific ones for acupuncture and musculoskeletal, which I will actually talk to you guys about as well. Some of these you may find useful and in your clinics, some you may not, but it depends on what you actually do as your therapies. What we will actually say is there's most of the PROMs are actually free and you are able to use them in clinic. There is a certain amount of them that do actually require permission to use. As a university or college, we have the ability to do that without having to pay. In clinic setting, you may actually have to pay. So it's just identifying which ones are actually free and which ones you actually need permission for. Okay, this is probably the problem, is when I'm actually on air, I can't actually move that down. Can you guys see that? Can you see the characteristic of PROM now?
Yes.
Really? Yep.
Yes, I can, yes.
Okay. Sorry about this, people. We're just dealing with a few technical issues. Okay, so just to give you an overview of what these patient-reported outcomes are, a well-designed PROM will actually assess either a single underlying characteristic or a multiple characteristics are required. A number of them will actually be incorporated into these particular questionnaires. Most of the questionnaires are either generic, which means it can be used in any disease state or population, or they're actually condition targeted, which means it may actually be one condition for that particular patient or group of patients that they're trying to measure. And this is used a lot in medical areas, but it can also be used a lot in complementary medicine areas as well. So particularly if you are specialized in one particular condition. Some of the most commonly used PROMs or questionnaires of this are things that look at symptoms, so some form of impairment or disability, also your functionality. So there's a lot to do with pain, there's a lot to do with osteoarthritis, knees, hips, those type of things. There's a lot with oncology, mental disease, as well anxiety, depression. There's still a lot that need to be established as well. Other ones look at health status, general health perceptions of how they actually perceive how they're actually going, and also quality of life. There's also health-related quality of life ones too, which are quite specific to disease states. There's also reports and rating on healthcare and how people are actually going. Sorry, I'm just going to shut the window because there's noise from outside. Okay. The whole idea of this and where we would actually like CAM to actually go, or complementary therapy to actually go, is patient-centered care. Now, as you guys have already learnt through your studies and what you're actually doing in clinic, is patient-centered care. Unfortunately, for a lot of the healthcare, that has been lost, but it's trying to be refocused. And the idea of it is this new focus or realization is the medical and healthcare is the patient is the center of their own health, and they have the right to be able to explain to people what is actually going on with them. So it's patient-centered care, it's individualized, and it is supposed to be for not just their condition or their treatment, it's about what they're actually going through, because everybody actually reacts to treatment or to their actual disease state differently. And these PROMs or questionnaires actually help us understand what is actually happening for that particular person, which is why it's great to be able to quantify what's happening at the beginning, if you've given this particular treatment, what actually happens after that treatment or during that treatment, and we can actually progress it through different stages that they're actually going through. So as I've actually said there, it's a new focus or realization in medicine that they're actually starting to implement this. the patient is considered to be the centre of the treatment, and it assists in obtaining direct feedback from the patient. And that is, to me, is actually really important because, you know, it's nice for us to have the subjective view, our assessment. We all have an educated ability to be able to see what's actually going on for a patient, but to actually have their feedback and know exactly what's actually happening is really important for our clinical assessment, how we actually progress forward. Therefore, the PROMs can actually enhance our treatment adherence and also their compliance. The reason I say that is that the patient actually feels that they have play a major part in their treatment choices and where it actually goes. So that brings us to the importance of the actual PROMs, and where we look at the patient gets to explain different aspects of their treatment and complaints or opinions on technology or observers that they don't always actually see, and this is actually very valuable for both the patient and the practitioner. And the practitioner then gets to evaluate very different aspects from a patient's direct feedback. And I'm sure you guys know, as if you're in clinic, that sometimes depending on who the practitioner is, how their interaction is with that particular person, the patient may not always say what they're actually feeling. So, and then you also get that perception. If they actually write it down on a piece of paper, sometimes you'll actually get a more honest and genuine response rather than telling the practitioner exactly what they want to hear. In some conditions, survival is also not the ultimate goal. So assessing the life play or of an essential role is actually important. So we're looking at our quality of life, you know, particularly side effects of medication or of our own treatments that we're actually doing. And practitioners also have a quality measure for the treatment of outcome, and that can also be subjective. So what are we trying to do with our outcomes? And these can actually be broadly classified into 3 different areas. We'll actually find that some of the PROMs are clinical. This may be to determine a cure or survival outcomes. This is mostly to do with chronic disease areas. So you're looking at things like cardiovascular disease, looking at things like cancer. They're probably the 2 biggest ones. Diabetes into that as well when we're looking at that chronic disease outcomes. Humanistic, these outcomes assess the role of performance or emotional status of the actual patients, and so how we can actually do that. It's like the psychosocial type aspects, which can be extremely important when we're looking at patients, because we do want to have that holistic type view. To me, this humanistic side is one that we can play a major part in. Also economical. So some of these outcomes we can actually use to assess expenses, savings, and helps to assist or do economic analysis. So particularly some of the quality of life ones that we'll actually talk about, like there's the quality of life one that we can actually use for assessing our economical analysis, saying, okay, this is the outcome, this is how much it's actually going to cost using complementary medicines versus, say, medical expenses, and look at that in comparison and see, okay, what is going to be economical balance for people. So maybe the lower social economical people, when they actually get on PBS, the economical value of expenses is actually better on a medical side. However, on a middle class to higher expense people, you're probably actually better using the complementary medicine side for the outcome and survival rates, and also the quality of life of the person. In the clinical environment, outcomes can also be reported by a number of things. You can actually do clinical or clinician reported ones, which is the performance of the patient. You can also do a caregiver's report, which is a functional status. So we have a number of people when we're looking particularly for chronic disease, that a caregiver will actually be a better person to fill out the questionnaire rather than the actual patient themselves. You have the physiological, which is a tumour size, say from an MRI, so you actually have the quantitative measure from that, or say X-rays, CT, any of those. And you also have patient-reported symptoms, which they can explain what is actually going on for them. Other outcomes that can actually be used, you have an observer reported outcomes, and these are outcomes which are completed by researchers or the actual caregivers themselves. So there's certain PROMs, one of which I haven't put in, it's say for gastrointestinal one, which say a researcher or practitioner actually needs to ask the people to actually get the responses, or a caregiver can actually do, because they're the ones actually seeing what's happening for that person. So if a patient is revealing that they're experiencing, say, morning stiffness, and the clinician is asking them the morning stiffness such as severity and nature, that will actually give us an observer-reported outcome. Also have proxy reported outcomes, which are outcomes reported by someone, the patient, but they're not reporting it as, sorry, let's explain that again. They're pretending that they are the actual patient, and so they're reporting it as if they're the patient and this is what is actually going on. So it's a proxy type thing, and a lot of this happens for people who can't actually speak English, or have people who are like their main carers as a child, and so the parent will actually say it as a proxy outcome. So before I go on to examples of problems, that's just a very quick overview of what we're looking at, patient-reported outcome measures. Is there any questions before I go on to specific examples?
Hi, Dana. I haven't received any at the moment, but I mean, anybody, if you do have some at the moment, please type them in and we'll ask them. If not, I think it's okay to proceed at the moment, Jenna. Yeah.
And fantastic. So what I'd like to do now is actually go through specific reported outcomes that clinicians or practitioners can actually use in a normal practical setting or clinical setting. So the first one is for anxiety, and it's called the GAD-7, and it's a general anxiety disorder, and it's a 7-item scale. And this one is free of charge. You can easily use this in your clinical setting. And it's a self-reported tool for screening and measuring anxiety. It's really easy to complete. It's very reliable, and all of these that you'll actually see have been validated to make sure that they are consistent in their reliability. This can actually be used both just to assess somebody if they actually have anxiety, but it can also be used to assess how your treatment for anxiety is actually going and if the anxiety is actually decreasing due to your treatment options. Really quick one. It only takes 1 to 2 minutes to complete. So this is the actual GAD-7 that you can actually use, and it just shows you. There's only 7 questions. They mark it on where they actually sit on the, how often they're actually getting it, and it gives us a total score. So, and like I said over there, it's over the last 2 weeks. So it's not just a daily type thing. It actually makes the person think about what's happened over the last couple of weeks. Very good tool to use for people who actually have anxiety, and as most of you as practitioners probably know, anxiety is like a major thing that's actually occurring within society. The prevalence of it is definitely increasing, and I think that's got to do with the amount of stress, social pressures, and everything else that actually comes with daily life. The next one is PHQ, which is actually a patient health questionnaire, which is for depression. Now, you may have also heard of the DASS, which is also one for anxiety and depression. These are more specific ones that are used for depression, and like I just said, the GAD-7 is actually used for anxiety. And this is actually used for mental health in general for a lot of doctors, and we can actually use this as practitioners in our general practice. It's also very quick, user-friendly, and aids in the recognition if that person actually has depression. Again, it's also valid and it's reliable. It only takes, again, 2 to 5 minutes to complete. So these are really quick little questions that they can actually do. This is the actual patient questionnaire. 9 questions on this. Again, you actually rate where you actually sit over the last 2 weeks, and you get a total score. And that gives us a good indication of where the person is at. People treating depression are usually can go through a range of different things. Depression can swing in different areas, and it's really good to find out what treatment is actually working for that person, because when as an individualized treatment option, we definitely see that depression can't be treated the same way for every person. So this gives us a really good example of how we may be able to tailor our treatment options for that individual. The next one is the Insomnia Severity Index. Again, a very quick PROM that we can actually use in clinic to see how their sleep status and how that person is actually responding to treatment. I'm not sure how you guys go in clinic, but I have insomnia or sleep issues, I would say, in 90% of my patients. And this is a really good little tool to actually see how we're going. And I'm sure most of you have actually seen that a lot of our things that we use doesn't always work on people, and we sometimes need to use a number of different techniques or modalities to be able to assist them. So this gives us a very good quantitative measure of what is actually working and where we actually need to go. So this shows you the insomnia index severity PROM, and we can actually look through if it's difficulty getting sleep, staying asleep, or if it's waking up too early and not being able to get back to sleep. So you can easily use this both for identifying insomnia or sleep issues and then quantifying your treatment options. This one you do actually need permission for. We've actually got permission for it through Endeavour College. However, unless you're actually going to publish the use of this, you are able to use this in a normal clinical setting. Only if you're actually going to publish information from this in some form of journal will you actually need to get permission to use it. Okay, there's a number of pain PROMs which I will actually go through. The Madasi is the one we've actually chosen for the Endeavour colleges, mainly probably because I like the MD Anderson approach on pain and quality of life, but they have some very set pain questionnaires which can be used in specific disease states, and these have been used throughout a lot of research, and this is really important. However, we can also use them in a clinical setting. So this one is an inventory for a multi-system reported outcome measure, and can actually be used for both screening and treatment options for pain management. It's really easy to use, and it addresses pain, not only what that person is experiencing right now, but how that actually also interferes with their daily activities. And people with particularly chronic pain or acute pain need to find out of how it's interfering, because that's also a quality of life thing, because pain can actually be a major interference for people, and as most of you probably know too, that can actually lead to a lot of anxiety and depression and social interaction that has now been interfered with. So the pain itself can also stop them from eating things because they may not be able to open cans or have the ability to stand for a period of time so they can actually cook a meal. So this actually helps us look at what they can do in their daily activities and how that's interfered with. And again, it only takes 3 to 5 minutes to complete. So this is what it actually looks like. There's some of the core ones that you're actually looking at. What is your worst pain over 24 hours? And then how it actually interferes with their enjoyment of life, how they interact with different people, if it's working, if it's walking, all those type of things. Sorry, that just jumped ahead. So you then actually can do 2 different scores. One is what they're actually feeling right now and how their pain is assessed, and then how it's interfering with their life. And again, you can actually use this for assessment at the beginning, but also with what treatment that you're actually currently doing. The next one is a menopausal rating scale. This is obviously utilised for women and not so much for men, but men obviously go through an andropause as well, and some of these tools can actually be used for men as well. But in most of the cases, it will be the women who will actually come to you who are going through menopause, and each lady experiences this very differently. Again, this is very easy to administer. Again, it can be used as a screening tool, but also to monitor treatment. And because, like I said, most of the ladies who are going through menopause will actually have presenting symptoms or signs at different stages. This can vary depending on where they are for perimenopause, menopause, or post-menopause, and we will then adjust our treatment options depending on what they're actually experiencing and what they say is actually going on. So again, this only takes 2 to 3 minutes to complete. All of these type of forms can actually be kept in their file, and we can actually go back on it and we can actually track it and even make a graph to see what is actually going on for them. So this shows you the 11 different ones that we look at for menopause and where it sits on it, if they're not experiencing it, if they are actually experiencing it, and over a period of time, because when you're looking at menopause, you may actually have patients, who are seeing you for menopause for up to 10 years. Tracking that on a graph is actually really good, and you can actually see which symptoms are becoming more prevalent for them over a period of time and which treatment actually works better for them. Okay, this is one of the quality of life questionnaires that you can actually see. It's a quality of life that I said you can also actually use for economical analysis, and it's the one that's now been chosen for most of the research and publications that are actually coming out. You would have actually seen the SF36, which is the one that used to be used quite a lot, but from that one we can't actually do an economic analysis. From the EQ5D5L, there is a set protocol that we can actually use to do economic analysis, which actually helps us to evaluate the cost per patient for this particular treatment and if it's actually worthwhile. So it's very simple, it's very generic, it can be used both in clinical settings as well as for research settings. It indicates up to 5 dimensions of quality of life. It looks at things like mobility, self-care, usual activities, pain, discomfort, anxiety and depression. A general questionnaire that can also be used and it can take up to about 5 minutes. So this actually shows you what this questionnaire is. It looks at, like I said, the mobility. It actually shows you there's 5 questions per section that we can actually do, and you can actually fill it out. Most of the time for quality of life you can actually use this or the SF36, but again you can actually show that in regards to the quality of life. The McGill Pain Scale is another one. This time we're actually probably looking more at things where you're dealing with chronic pain. It's a rating scale, it's very easy to use, and it's been very, it's a free one that a lot of massage therapists and acupuncture people actually use. Again, it's a self-reported questionnaire that allows patients to give a practitioner a good description of the quality and intensity of the pain that they're actually experiencing. Basically, the patients select a single word from each of the different groups that best describes their pain that they're currently experiencing. They then select 3 words from a different group that best describes it, and then 2 words from another section, and 1 word from the last couple, 1 from 16, and then the groups from 17 to 20, which I'll show you in a second. And these words can then be used more than once, but they show you, it's probably not that clear, what that person is experiencing, and you can then actually use that for your actual treatment. Like I said, it's actually used a lot for massage and acupuncture, but there's no reason why other modalities can't actually use that to show them what is actually happening for that person, particularly if you're treating chronic pain. Because if it's a sharp pain, if it's a dull pain, you know, if it's flashing, shooting, all of these type of words that they're actually choosing helps us to design the right treatment options for that patient. The Arabro Musculoskeletal Questionnaire is probably one of the most well-known ones. It's used by doctors, medical fraternities. Most of the different physios actually use this, osteopaths all use this one type things. It's one of the yellow flag screening tools that predicts long-term disability. And if any of you guys are doing things with EPCs through your doctors or workplace and health type things, this is the most common questionnaire that's actually used, and it's very good to be able to use in your clinics to then justify to the insurance companies what's happening for this particular person, and if they can actually return to work after they've been injured or things have actually happened. There's a score of 105, and this actually predicts who will actually recover, those who will have no further sickness, and those who will have long-term type sickness, which is why it's actually used a lot for insurance companies and companies in themselves to actually see if this person's going to return or not and what's going to occur. So this actually shows you the questionnaire itself. Again, this is a free one that you can actually use quite easily within your clinical setting. And like I said, if you're actually doing anything to do with work health and safety, or people returning to work, or even if they're possible some form of legal intervention, I would highly encourage you guys to use this one to quantify what you're actually doing and how the person's actually going. So that's the complete questionnaire. The Oswestry is probably the other one that is most well known, and again it's actually used for low back disability. and it's really important for both researchers. The researchers use this extensively for disability and evaluation, but also a lot of clinicians use this, and then, like I said, it's mostly the things like physios, osteopaths, massage, and even some of the acupuncturists actually use this particular one, but a lot of massage therapists are now using this as their gold standard for low back pain analysis. There's a whole score that comes out of 5 for this, and there's 10 different sections that comes to a calculation of 50, and it shows what that percentage of that person is for low back pain. This is the interpretation of the actual scores. I've put this before the questionnaire itself, but it shows you if you have a percentage between 0 and 20, you have very minimal disability, so the person can actually usually cope with daily life activities, able to sit for long periods of time or stand, but will still have some minor back pain. The 21 to 40% is moderate disability. It actually has a bit more pain, a bit more difficulty with standing, travel, interference with some social things, sexual activity, even some of the personal care. When we go from 41% upwards, we start to look at more severe disability, and this may be a major problem when we're looking at chronic pain. Then we look at 60 to 80%, the person is actually crippled, and then 81 to 100, the patient is basically bed-bound and cannot get out. So this is the Oswestry lower back pain questionnaire. Like I said, there's actually a whole range of different sections. There's 10 of them that actually has different questions in each to give us a good understanding of what is actually going on with that person, how this pain or back pain, this particularly lower back pain, is actually interfering with each of these activities. On a different one, we look at a headache disability index. Headaches can come from a range of different etiology, and sometimes people know what that is, some people don't, but we can actually quantify for these people how the headaches are actually going with treatment. This is, can actually identify the treatment options for this particular patient if you want, but most of the time it's more evaluating how we're actually going with treatment options. It's a 25-item questionnaire, and they either answer yes, sometimes, or no, giving us a certain point system, and this has really good, strong consistency and reliability. So if you have people who actually have a lot of headaches, which again I find quite prevalent with patients, this assess with what you're actually doing, and obviously it's not just direct treatment, we're looking at your lifestyle treatments, their sleeping, energy, what we're actually implementing, not just on supplements, herbs, if it's acupuncture or massage. So a very good one to assess people with headaches, and you can also use this to a certain extent for cluster headaches and migraines. Fear avoidance beliefs. This one isn't just a psychosocial type one, but it's actually looking at or investigate the fear avoidance of certain things in a clinical setting, particularly to do with pain. So it predicts those who have a pain of high avoidance technique will have a different response to treatment to those who don't actually have it, and they've actually clinically found that patients with a pain avoidance behaviour may actually need to be supervised more than those that actually confront their pain. So what that actually means is that people who don't want to know about their pain will actually not explain that to you, may actually need higher supervision when they're actually having treatment with their exercise regime or what they're actually doing than those who actually state quite clearly what they're actually experiencing. So there's 2 different sections. The first section that we can see is my pain was caused by, say, physical activity, things that have actually done that. The second section is how it affects their life, their work, and how they feel about that. So this is actually quite a good one to see how much supervision or what is actually required for that particular patient. We're getting probably more into the physicality type problems. This is a hip dysfunction and osteoarthritis outcome one. Again, it's a 40 questionnaire. It actually incorporates the WOMAC. If you know what the WOMAC is pretty well the gold standard for knee issues, but this actually incorporates a whole lot, and we can actually look at how the hip as well as the knee function. So your WOMAC is something you can actually use for both research and in clinic, but so is the WHOS. This actually just shows you the whole questionnaire. It's actually quite extensive and gives you a very good analysis to see how your treatment is actually going. The NEES or the KOOS is actually really similar to the, so like the KOOS and the WHOS, but the knee function one is specific as well as the hip function, very similar type questions. This one actually looks at the knee injury and any post-traumatic stress leading to osteoarthritis and how likely that person is actually to get osteoarthritis from a particular knee injury. Again, you'll actually see that the questions are very similar to the last one, and this again is all free. We've now got the LEADS assessment, which is a neuropathic one, which looks at signs and symptoms, and this actually helps us to see if the person is actually experiencing nerve pain versus, say, general musculoskeletal or inflammation type pain. It's a very simple 5-symptom questionnaire that people can actually fill out. The only problem with this one, it does actually require a trained professional to assist in one section of it. So what you need to do is light brushing or a pinprick type thing to actually see if it is small nerve involvement which can lead to neuropathic pain. And again, it comes out as a score of 24. So a lot of you may not actually use this one in clinic, but it is something if you are looking at nerve pain and how people assess things. For me, I actually did my PhD in chemotherapy peripheral neuropathy, and this is something that I use actually quite a lot. I've got specific tools in clinic whereby I can actually assess light brushing, so I've got a specific light brushing for peripheral neuropathy, and also then a pin status to see how much their small nerve damage is going, where I can then grade the damage and how my treatment is actually going for that particular person. We also have a neck disability index. This one is very similar. It's a modification of the OSTRI type thing, but it looks more just at the neck style of things. If you have people with whiplash or major neck issues, this is probably something that you would actually look at. Same thing with shoulder pain and disability. If people actually have some shoulder pain, or even if it's a frozen shoulder style of things, again, you can actually use this one as an initial consultation, but also to see how your treatment is working. These again are all free that you can actually use. Last one, I think, is the upper extremity functional test, and this is a very simple Likert scale where they actually mark it on there how their upper extremity is actually working. Very easy to administer and is easy to replicate. So the person can actually just fill it out, how their actual normal work activity going, how it's actually interfering, and what they're able to do or not able to do. So in conclusion, I've gone through these fairly quickly for you. For me, patient-reported outcome measures are a really valuable clinical tool, and I think they're really underutilized at the moment. A lot of us have been taught, and like I graduated like nearly 20 years ago, so these type of things were not actually taught to us. We weren't actually educated on them. However, in saying that, this is something for me which can be very valuable that you can actually use in a clinical setting, which actually quantifies how your treatment is going. And a lot of patients actually really like it because they can actually see from their own interaction of an explanation of what's going on for them, the change from, say, from the beginning to this section to the next section, and you've got something, quantification, rather than you subjectively saying, oh, you actually were like this last time, but now you're actually saying this. They can actually look at the score, they can see the difference, and it actually helps with compliance as well as the ability for your clinical status and showing if there is like a court case or interaction with other practitioners. They also provide concise measures to show if your treatment is actually working, like I just said, and they also give you a quantitative measure rather than subjective. We are really going towards patient-centered care, and I think if you are interested, please look at these type of PROMs or patients-reported outcomes and try to incorporate them into your clinical practice. Depending on what your speciality is and what actually works, you can pick and which one is actually more appropriate. what I would encourage you to do is actually make sure that they are valid, they're reliable, and they have been tested for the precision and are used worldwide, not just on something that is just given out and said that this is actually used easily without any quantification of its reliability, validity, or repeatability. So that probably ends my talk for you guys. Is there any questions or things that you would like me to explain?
Hi Janet, Raleigh here now. Thank you so much for the presentation. There's so much that you covered as part of that. I mean, so it's very impressive. We definitely do have some questions. So we've got 15 minutes left in the session. So I'll just, some came through at different stages. So I mean, I've tried to X them out. Traditionally, do certain modalities use specific PROMs? Because I know as you went through, you said, oh, this one's more for certain type of modalities, but are there some, say, if naturopaths were getting together, would they tend to use 2 or 3, or is it just across the board depending on what they're treating?
No, there's definitely ones that are more specific for a modality. So part of it is what you see mostly in clinic, but I think it's always good to have an array of them that you can actually use on a regular basis. What I would actually say, if you're a naturopath, probably the ones that are most important would be quality of life, a depression, any anxiety, type 1. You'll actually find the insomnia one is really important because you will have lots of people, and it looks at your treatment options. And then depending if you see a lot of menopausal or ones, you can actually use that. We actually looked at a lot of the perimenopausal or the premenstrual type ones, but there's nothing that is really gold standard or things that you can actually use that has been validated properly. So we're looking into that at the moment, and that would actually be another really good one for naturopathic style. But again, it comes down to what you actually specialize in. A lot of the ones I just showed you, particularly at the end, is probably more for massage and acupuncture than it is for, say, naturopathy. Things like homeopathy use things like, say, MyMop is probably a little bit more specific for homeopathy. So again, it does depend, but yes, some of these are much more specific for a particular modality, but it really comes down to what do you see most in your clinic setting.
Yeah, great. So I'll touch on that point again. What I'd also like to ask the people online, what exposure have you guys had with PROMs? Are you using some at the moment? If so, I'd love to see what you are using and what your experience has been. But to go back on what you just said there, Janet, so do you think for people that aren't using PROMs, it's about reviewing their patients and also how they treat them, and then have an arsenal of PROMs just ready to go, I guess, to use? Is that how you think?
I actually definitely think that. Yeah, sorry, I didn't mean to cut you off, but I definitely think that is the case. You know, like I said, we were originally taught it's very subjective. You ask the patient, you know, as a follow-up, how they're going on these type of things, but you never actually have something that is quantitative to actually show them how they're actually progressing. And the other thing that comes out of that is that we never have anything quantitative to actually see if what we're actually doing works. You know, our subjective and thought patterns for that particular person might actually be there, but to actually have something that quantitatively shows, you know what, I actually did this particular treatment option, and this outcome measure showed that this was actually working for that person. And that's good for both the practitioner and the patient to see where they're actually progressing, but it's also good to know, if this isn't working and this has actually got worse, then we need to change our treatment protocol because that wasn't working.
Absolutely.
And what I think is that we should all have, like you said, an arsenal of different PROMs available, so that, okay, this person's actually presenting with this, fill this out. You say, as you saw, most of them only take 1 to 2 minutes to actually complete. It doesn't take long. And if you know that that person's actually coming back with this particular problem, they can actually fill that out while they're sitting in the waiting room and then bring it in, and then you can actually then compare, show them. So I think having a range of ones that you can actually just bring out and use on a regular basis is actually really important. But I really like the idea that we can actually quantify what we're actually doing, because we haven't been able to do that previously.
Yeah. We're You've just thrown a good segue into the next question I've got here. Just in regards to, now I've lost it now. I started celebrating and it's gone off the screen for me. Yeah, somewhere. I'll just throw this other one in there. So we've got a few more in. Just wondering if there is a reliable digestion prom you can suggest for IBS?
There is one for IBS. I didn't put that one up there, but there is one that is actually specific for IBS, and it's called the IBS questionnaire, and it is also free, so you can actually access that. If you put it, like Google's doctor is just amazing, isn't it? But if you actually put it into Google, it will actually come up. The one that we're putting into Endeavour is called the GSRS, which is a little bit more in-depth for general gastrointestinal type outcome. However, if you're treating a lot of IBS, there is one specific one used just for that.
Great, thank you. Another one. What you've shown tonight is, obviously you've gone through just for screenshots for us. Are there online versions, and how do we, or how do practitioners go about accessing them? Is there a database to say, well, these are the different ones available? Because you obviously probably just touched the surface, I imagine, tonight.
I have. I can't show you all of them because there's so many of them.
Yeah.
I just tried to pick out ones that I thought would be more relevant to people right now. Yeah. But the easiest way to get them is you can actually go online and put these in, and you'll actually be able to download a PDF of them, and you can use that in your clinic. It's very easy to do, which is great once you actually know it. But if you're unsure and you have a particular area, because like I said, this is only a few of what is out there. If you have an area that you're actually working in and you want to know if there's a validated test or a prom that you can actually do, what you can actually do is put in patient-reported outcome for that particular condition and see what actually comes up in, say, Google, and it will actually show you a list of them. If you're ever unsure, you're also more than welcome to contact me at the Office of Research at Endeavour, and I'm happy to help you out or show you ones that I know of in those particular areas. And like you'll actually find there's only some that you do actually need permission for, and they will actually have sample on, but you can still get the PDF of it. But most of them, if they're actually free, you'll have the PDF easily accessible from Google.
And I think just to touch on that, how you said yourself, but I mean, anything you get from Google these days, just need to be careful with what it is. So, I mean, I guess talk to your peers or colleagues if Janet's not if you're not going to contact Janet, just to make sure, see who is using it. But
you will actually find that a lot of them will actually state if they are free access or need permission.
Okay, great. Moving on, we've got about 8 minutes left to be precise. I've got, where do we find which proms we need to pay for in clinic versus which ones are free to use in clinic? That's the same again? Is that the...
It's exactly the same again. What you actually do is when you look at them online, they will actually say this is actually free to use, or permission is actually required to use this in these settings. What we actually find is that some can actually be free to use in a clinical setting, but if it's actually used from a university or stuff like that, that you actually need to pay.
Yep, that makes sense. Is there a difference between proms in Australia versus another country, say the US?
No, the whole idea of proms is actually to be universal.
Okay, excellent.
So that they should be able to be used worldwide. That's the whole idea of the research being validated, making it reliable and consistent. So there is studies that are actually done and published in, say, like if you look in PubMed or on Google Scholar and all those type of things, actually showing the reliability and validity of these particular ones, and they can be used worldwide. A lot of these are available in different languages depending on what is the place they're actually used, but all these proms that I've actually showed you and a whole range of other ones are the set ones worldwide.
Okay, great. Flicking around a bit here, so I remember when you said in regards to the insomnia prom about you need approval to publish it, but you can use it within your clinic. So
correct.
By publishing it, it would mean by, say, if you're a researcher, etc., and you've got the results to actually write an article from it. That's just to clarify.
That is actually to clarify, yes. So you can actually use the Insomnia Index in just your clinical setting to assess your own private treatment protocols and all those type of things. However, if you are a researcher or you're wanting to publish a particular case study in a particular journal, you will actually need permission to use that PROM, and also the patients need to fill out permissions. What do you call it? Oh my goodness, I'm just having a mental blank. Isn't that terrible? They actually need to sign to say that they give you the permission to use this information.
That makes sense.
But that's the only time. Other than that, it's actually free to use in clinic.
Right, thank you. Do you know of any thyroid disease PROMs?
At this stage, there is a number that are actually out there, but a lot of them still need to be validated and concise. If you want to contact me, I can show you a couple, but there's none that I would feel that are totally reliable.
Okay, so after tonight, I'll send out the PowerPoint and also Janet's contact details. Just your email address. Would that be okay, Janet? Yeah,
absolutely.
Okay, great. We've just started the questions come rolling in now. How do we use these PROMs without falling into focusing on disease, condition, and maintaining holistic and naturopathic diagnosis?
That's a really good question, and the reason I'm saying that is because this isn't focusing on a disease or condition. It's actually focusing on a patient's perspective of what's actually going on for them, which falls really well into our holistic ability of patient-centered care and what's actually happening for that person. Yes, these are specific for a condition, say for insomnia and stuff like that. However, it's giving you the patient's perception of that, not our perception of what's going on for a particular condition. So for a lot of people, you're not going to just use maybe one. You may actually use, say, 3 or 4 of these. You're still going to conduct a normal consult. You're still going to ask all your other questions, and you're going to put that together for that particular person. However, if they've got one area that you're going to focus on, this actually helps to quantify your treatment for that. But it doesn't take away that holistic perception, and I would hate for a person to actually work on just a treatment protocol or just a disease state, because the whole idea of this is patient-centered care.
Yep.
And individualization.
Definitely. That was a good challenging question though. I liked it.
Yeah, I like it too.
Yeah. At what frequency do you have the patient redo the questionnaire?
Depends on what you're actually assessing. So for some people, if they're coming back and it's anxiety or depression or say insomnia, you may actually get it. If they're coming back to see you, say, every 2 or 4 weeks, then you may actually get them to fill it out just to see how they're going, especially because it only takes like 1 to 2 minutes anyway. For other things, it may vary. For, say, some of the different gastrointestinal type things, you may actually not do it, say, every month or 3 months. So it depends on what your treatment and how often you're actually bringing them back. For some of the neuropathic pain one, I don't do it every consult. I would probably do it every 3 months.
Okay, great. And we've got our lucky last question, and it's pretty much ended us on time. Just when we were talking previously about that we need patient permission to collect the data, is that in clinic as well, or just in relation to publishing?
Publishing. Publishing and research. If you're going to use research or publication, you actually need the patient or client's consent, and they need to do a consent form in regards to that. Other than that, you actually do not need the patient's consent to be able to use these.
Okay, great. That was, as I said, that's our lucky last question. So it is 6:30, so I want to thank everyone for joining us tonight on an Easter Thursday, so I'm sure a lot of life pressures were pulling you away, but so thank you for making the time to come in, and most importantly, thank you, Janet, for coming along and teaching us so much about PROMs, and I'm sure this has triggered a lot of interest.